Oh, there it is. Hello and welcome to Under the Microscope at the 2020 Florida Society of Otolaryngology meeting. My name is Mark Widick. I am a private practice neuro-otologist, having done my fellowship and residency at Vanderbilt University and at the otology group under Michael Glasscock. I've had the pleasure of practicing in Boca Raton, Florida for the entirety of my career and have been participating in the Florida Society of Otolaryngology meetings where I served as president many years ago and continue to give lectures on interesting topics in otology. I was invited to give this lecture and am looking forward to sharing my thoughts on what is the target audience. The target audience for this lecture really is somebody that's looking for a refresher in otology, a resident level in training, as well as non-physician providers who are looking to increase their depth of knowledge and their clinical acumen when it comes to diagnosis of pathology in the ear. The ear is a complicated structure and is often misdiagnosed in my experience. It is with this theme that I will proceed in a way of trying to point out what are many of the errors that I see routinely when patients are seen by myself in the clinic and have already seen other providers. One of the most frustrating situations is where there may have been time-sensitive diagnostic clues that were missed, and the time sensitivity of the diagnosis results in a less than optimal result because the patient eventually sought me out on their own because the diagnosis that was made was in error and their situation for that reason has failed to improve. To this end, I will try to teach some of the pearls in the examination of the ear, both the external ear and the middle ear, with emphasis on the more common diagnoses that you are likely to come across, and focusing on what diagnoses are often missed and the potential problems that can occur to the patient and to you should that happen. So the examination of the ear is not a simple matter. It is a very small opening that requires examination, and illumination is difficult and magnification is essential. Often there's obstruction such as earwax or natural osteomas and exostoses, which may cause difficulty in examining the ear. The pathology of the ear also can cause narrowing of the ear and make it impossible to examine. The otoscope is a traditional means of examining the ear. It consists of a speculum, a light source. Light source is often adjustable, and an eyepiece that offers some magnification. There may be a rubber bulb also attached so that you can try to puff air into the ear canal and look for mobility of the tympanic membrane. This is the traditional instrument, and it has a lot of problems. It only allows you to look through with one eye, so you're not getting the three-dimensional view. The magnification is somewhat limited. It does not allow for documentation. And for this reason, I have begun to use in my practice both to document and to diagnose these small digital otoscopes that have become available through the internet and sites like Amazon and eBay. These instruments are extremely affordable. You know, they're not marketed to physicians based on their price. They are marketed to the end user. And the intent of most of these is for home treatment of cerumen. They run typically a very affordable $30 to $40. The newer ones have Wi-Fi. The older devices had a USB connection, and for the most part offer acceptable image quality and images that in many cases exceed what you would get with the otoscope. And so for this reason, I am really, really strongly advising everyone purchase one of these devices, both so that you can document what you're seeing. You can easily send these images as attachments through HIPAA compliant devices. For secondary opinion, they're excellent for telemedicine. And many times I feel that they do a better job of illustrating the translucent nature of the tympanic membrane. They're very easy to use. This is example of doing it on myself. The ear canal in my case has large osteomas and some cerumen that chronically plagues me due to the large osteomas that I have that were most likely due to growing up in Florida and doing a lot of swimming in cold water. The routine ear examination is performed on new patients, even if they're not complaining of ear problems, and often will result in the diagnosis of cerumen or other benign conditions that should be noted in the chart and may need treatment even if it's not the patient's primary concern. I also encourage that those of you who are still in training, to examine as many ears as possible, as you need to get an appreciation for normal, and there's a wide range of normal when it comes to examination of ears. And thick eardrums, tympanosclerotic plaques, which are thickening of the fibrotic layers within the tympanic membrane, can often be confused with pathology. But if you're looking at a patient with no complaints and normal hearing, you'll begin to appreciate the variety of normal findings. I'm not going to dwell on the anatomy of the external ear canal. The tragus is a useful landmark for the temporomandibular joint. And often if the pain in the patient complaining of otalgia is located over that area, and if you can elicit crepitance or other abnormal finding with opening and closing of the jaw in the region of the tragus, and you're examined the ear canal is normal, then you can avoid giving antibiotics and other unnecessary treatments for an otitis that doesn't exist. There are obviously many congenital abnormalities of the external ear, and I'm not going to go over the details of these other than to just familiarize you with some of the appearances that you might find. Otitis externa is present in the right too, with the far right image representing a classic picture of chondritis, where the conchal cartilage is inflamed, sparing the lobule, which is free of cartilage, and in this image, normal appearing. So the image here is of a normal ear canal, normal tympanic membrane, fairly typical access, absence of any significant cerumen. You'll note that the tympanic membrane is translucent. You can easily see the promontory just posterior to the malleus, and posterior to the promontory, you can see a darkened area, kind of accentuated by a small hair on the tympanic membrane, and the inferior aspect of that small hair is sitting right over the round window niche. All of these structures are typically visible, and I encourage you to always look for them, because that is the hallmark of a translucent tympanic membrane, that you can see these structures. And if you don't see them, you could still have a normal but thickened tympanic membrane. But if you do see them, then you can be certain that there is no fluid or other pathology. As I mentioned earlier, palpating over the tragus is a very good test for issues of otalgia that are not otogenic, with the temporomandibular joint being by far the most common diagnosis for the source of the pain. Now, some abnormal ear canals. Far left shows an extreme example of otitis externa with purulent discharge both in the ear canal, covering the tympanic membrane. This could be, and most likely is, a bacterial infection, although viral etiologies such as herpes can eventually degenerate into an appearance like this. The center image reflects similar but less severe changes with swelling erythema and irritation of the sebaceous glands. And then the far right image is a classic appearance of a fungal otitis. And although this certainly has a fungal component, I don't think anybody would assume that the fungus is the only potential pathogen, because we often have a mixed flora where the fungus is a opportunist sitting on top of an underlying bacterial infection, causing moisture and debris that the fungus is then thriving on. So most treatments will require a shotgun approach, and many of the Widick drops contain antibacterial and anti-inflammatory ingredients. Unfortunately, most don't contain antifungal, and I often will resort to a compound pharmacy to create a mixture of Cipro and ketoconazole, as well as dexamethasone, when I treat these infections. Now, not everything within the ear canal is pathologic, and here's an example of what appears to be abnormal findings with the ear canal, which are not really pathologic in that they don't need treatment. We have an exostosis in the left slide, which is in the typical location superior to the tympanic membrane, and often occluding pars flaccida in the examination. And in some cases will actually impinge on pars flaccida of the tympanic membrane. On the far right, we have osteomas, and these represent larger, more broad-based bony growths of the auditory canal that are often associated with swimming in cold water. The nickname for this is surfer's ear, especially prevalent in the Pacific coast of the United States. Common maladies of the auditory canal itself. By far the most common on the left is cerumen. Foreign material is frequently encountered, and suppurative infection. More dramatic findings can be foreign bodies, including insects, beads, foreign fibrous material. This is either cotton on the right, or may represent an otowick, which is actually intentionally placed frequently for treatment of otitis externa to help retain the Widick drops and help reduce swelling by gentle pressure on the ear canal. So I am going to review a little bit more of the normal anatomy so that once you're very familiar with normal, it becomes easier to decide what is abnormal. So first of all is to try to figure out if you can tell, especially on the slide, if it's right or left. The ear will angle away from you, so you can use distance. And although these are slides that are two-dimensional, you get an appreciation that the angulation of these is on the right and left, away from you, trending anteriorly. You can also tell by the angle of the malleus and the light reflex going away that they are respectively right and left. In addition, in many cases, you can see the incus and the stapedial tendon outlined on these slides here and here. More examples of normal. And the astute of you will note that these are mislabeled. We've got a left and a right backwards, and that was not intentional, but I wish I could have quizzed you on it. Again, it's a very clear, translucent tympanic membrane. There is a little bit of hair in the image. This region superiorly is pars flaccida, and then there's always a membrane fold, and reflected in a membrane that's in the middle ear space that you can't see, and then pars tensa, which is this portion of the tympanic membrane inferiorly. Again, you can see the round window niche. Landmarks include pars flaccida, as I mentioned before, the short process of the malleus, the long process, the light reflex, and a translucent appearance revealing, again, the round window niche, the promontory, and the shadows of the stapedius tendon right there. Perforations, of course, are very common. You may be tricked, especially if you're using a routine otoscope, in believing that you're seeing a perforation when you're really seeing a monomeric segment. And a patient who's not complaining or has no history of a perforation, perhaps a history of tubes in the past, this can be somewhat confusing. The monomeric segments in the tympanic membrane can be so transparent as to be difficult to detect. Each of these examples does represent a perforation. Typically, these are central perforations. All of the ones in this example are central perforations, varying in size from maybe 15% of the tympanic membrane to as large as maybe 50% here in the bottom right corner. Now, we're going to start discussing pathology. This top left tympanic membrane labeled erythema, that can clearly be normal. A small amount of erythema, especially coming down what we call the vascular strip, this region starting in the superior part of the tympanic membrane and coming along the malleus. Some erythema in that area is normal. And then the pathology increases in these other slides to where there's clearly fluid and bubbles and bulging of the tympanic membrane. Bullous myringitis is also common in the bottom right, where it will look as if there's fluid, but these are really blebs within the tympanic membrane itself, and there is no fluid in this case in the middle ear space. one more example of normal, steadily progressing B, C, and D to more and more levels of opacification and infection. Extra credit is for you to go through these slides and decide whether these are right ears or left ears. Now, cholesteatomas represent the next gradation of severity in chronic ear disease. In chronic ear disease is the presence of damage to the tympanic membrane, often the result of eustachian tube dysfunction and allergies that results in retraction of it and its involvement with the ossicular mechanism causing damage. In the left image, there is retraction of a left ear with the pars flaccida portion retracting into the incus bone, eroding the incus bone. And what you're looking at just posterior to the malleus is the top of the stapes bone and the stapedial tendon with no evidence of the incus bone. That represents late stage atelectatic ear disease and is a cholesteatoma without significant keratinaceous material. The second image from the left represents what most likely is a congenital cholesteatoma. And this is a relatively normal appearing ear with a white mass behind an intact tympanic membrane. There is no evidence of pathology to the tympanic membrane in this image, and it likely represents a child. And this is a finding of the pediatricians. Typically, it's often asymptomatic unless it has been left undiagnosed. They can get quite large and can cause problems if they aren't recognized early. If they're recognized at this level, it's a fairly simple procedure to have them removed. And then on the far right, we have varying degrees of pathology with A representing normal, B and C representing fluid, B acute and C being serous and more likely chronic, and then large perforations and a myringotomy tube. More examples of sick ears, erythema, and bulging. Often, eustachian tube dysfunction results in extreme pain due to lack of pressurization. The slide's trying to emphasize this. We have the ability now to treat eustachian tubes. Most of the treatments that have been offered up until now, including nasal steroids and systemic steroids and allergy treatment, have been fairly poor in their effectiveness. Although we still don't have an excellent treatment, there are now eustachian tube ballooning procedures that are getting more and more insurance coverage, and hopefully will be fully covered starting in January, and then conventional myringotomy and tubes. Now, one of the things that I think is most important, and if you take nothing away other than this, I will have succeeded in my my goals, and that is to emphasize that there is no excuse for not conducting a hearing test on an adult. All that is required for a screening is a tuning fork. They are very effective, and they're going to prevent you from making a misdiagnosis that is probably the most severe, potentially for the patient and potentially for you, and that is confusing a sudden sensorineural hearing loss with hearing loss associated with otitis media. The tuning fork test is a simple test. There's going to be a short video on how to do that There's the Weber and there's the Rene test, and they can easily distinguish between conductive and sensory neural hearing loss. The reason that it's important for you to master these is if you diagnose otitis media and it's really a sudden sensory neural hearing loss and your otoscopy skills were not adequate to determine the difference based on otoscopy, the tuning fork exam will, in most cases, distinguish between the two. So here's a short video. So failure to do that kind of testing will often lead to failure to make the right diagnosis, and unfortunately is terrible for the patient because treatment of sudden hearing loss, sensory neural hearing loss, is not antibiotics, it's steroids. And we can do intratympanic steroid injections. You can give systemic steroids if you're not comfortable with that, and can help prevent you from being served with papers for missing profound hearing loss that could have been treated. If you had a patient walk in and they were blind, you would emergently send them to an ophthalmologist. Unfortunately, the same urgency does not seem to occur with sudden hearing loss, and the disastrous nature of being deaf in one or both ears is something that might be avoidable, and certainly you want to do everything you can to document what type of hearing loss you're treating when they come in clearly complaining of hearing loss. So those are my key points. We are down to the last few seconds here, and I hope that I've been able to instill a little bit of information, perhaps a little fear in flippantly treating with antibiotics when you haven't established the type of hearing loss present. And with that, I wish I could open it up to questions, but the format isn't going to allow that. Feel free to contact me. My timer is up. So with that, thank you. And I hope you appreciate this lecture. Okay.
Did it cut you off?
Well, no, it didn't, but my alarm went off, so I knew I was right at 30 minutes.
All right.